Good afternoon, everybody. We're returning from the break now. I'm again one of the co-moderators, Jeff Lennox, and it's my pleasure to introduce Dr. Meredith Clement from the LSU, who's an expert in sexually transmitted disease prevention and treatment, and she's going to talk to us today about treatment and management of sexually transmitted infections. Dr. Clement?
Hi, yeah, thank you so much. I'm honored to be here. Just wanted to mention one thing. So throughout the talk, I will try to use the term sexually transmitted infections. This is the term that's going to be used with the new 2021 STI treatment guidelines that should be out in the very near future. And the reasoning or the rationale related to this is that STI, referring to the organism that's sexually transmitted, is thought to be a more inclusive term relative to STD, which refers to the disease state. So really just less stigmatizing and kind of places the emphasis on treating asymptomatic infection, which is one of the goals of our treatment. So moving forward, here are my disclosures. And then just to provide a brief outline, I'll go over some epidemiology, particularly that just recently reported earlier this month from the CDC on STI rates in 2019, and briefly touch on what we know about 2020. Then I will review the impact of the pandemic on the COVID-19 pandemic on STI control, and then provide some updates on STI prevention and treatment. And so the objectives of this talk, hopefully after listening, learners will be able to kind of more comprehensively and thoughtfully consider management of STIs and treatment in the pandemic era, also weigh the risks and benefits of antibiotic prophylaxis, and then finally describe the new updates to CDC guided treatment for gonorrhea. And so just to kind of jump right in with the epi overview. So again, earlier this month, the CDC released a report kind of covering 2019 data for gonorrhea, chlamydia, syphilis. And so what this figure shows is that for the 6th straight year, rates have increased. And so breaking new records and records we really don't want to break, but so that we're approaching 2.6 million cases for gonorrhea, chlamydia, and syphilis. Here you can see the actual numbers, and I just wanted to draw special attention to congenital syphilis here. Almost 2,000 cases reported in 2019, and you can see that represents almost a quadrupling in number of cases from 2015. So really thinking kind of trying to emphasize here the importance of screening and paying attention to the guidelines in terms of screening, and that really screening in the 3rd trimester recommendations are based on kind of local prevalence data as well as maternal risk factors. So here is 2020 data. I will emphasize that this is not official. These are not official numbers, but this slide was presented at the National STD Prevention Conference back in September of 2020. So kind of drawing your attention here to the early months of 2020 when rates were exceeding what we saw in 2019 for primary and secondary syphilis, gonorrhea, and chlamydia. And then you can see in March, as the nation came under stay-at-home orders or was under lockdown, kind of this plummeting of cases, and then now this gradual increase in cases over time over the rest of 2020. And so I think it sort of remains to be seen whether this decline in cases is related to the lockdown and sexual distancing practices versus the clinic closures that were happening. And so that kind of segues us into thinking about the pandemic and the impact it's had on STI control. So to say that the pandemic has been detrimental to efforts to fight STIs is probably an understatement. So really, we had a public health crisis in STI rates prior to COVID-19. So if you think about the 2019 data I just presented, really just a public health crisis, and then add to that on top of that a pandemic, which has really exacerbated things. So STI clinics have faced things any clinics have with clinic closures, PPE shortages, modified hours, kind of this transition to telehealth. But on top of that, you have the folks in the STI field who actually have experience and expertise in contact tracing and disease intervention services. And so there's been a lot of redeployment of STI personnel to fight the COVID pandemic. And so they've done national surveys to kind of think about STI programs and the impact on resources. And in 2020, 87% of programs were reported that they were involved in their city or state's COVID-19 contact tracing. More recently, so they kind of repeated these surveys over time, currently 37% are reporting that their staff have been redeployed to the COVID-19 response. And that's actually a decrease from kind of 2020 when as many as 78% of staff were redeployed to the response. And then many programs are also reporting interference with STD control, so reduced disease intervention services. And these are the folks who are in charge of tracking down cases and partners and administering treatment in the field. And so those services have been reduced for gonorrhea, chlamydia, and syphilis. And so just another challenge I wanted to highlight briefly is shortages. Many people in this course may have heard of these or maybe have seen these firsthand, unfortunately. But shortages, I tried to be alliterative here, but related to staffing, supplies, and solutions. So the staffing I just kind of touched on in the last slide. But staffing shortages involved in kind of the testing and contact tracing that I just showed, but also now with a vaccine administration and distribution, you have jurisdictions utilizing DIS or disease intervention services for vaccines too. So 29% of jurisdictions now utilizing DIS for vaccines, and 8% more will be very soon. Many of you also may be aware of these the shortages related to supplies and swabs. So 35% of CLIA certified labs as of January are reporting supply shortages, and that's actually down a lot from where it was earlier in the pandemic, as I'll show on the next slide. And then molecular testing machines have been diverted to COVID testing, and then also just personnel within micro labs as well. And then finally, azithromycin shortages earlier in the pandemic when it was either being used to treat COVID-19 or concern for concomitant community-acquired pneumonia. There were shortages, and then also Cefixime and Gent were reported to have shortages as well related to supply chain and distribution. And so here is where we were in January, 35% of labs reporting testing supplies, but actually that's a huge improvement from where we were in the latter portions of 2020. So how do we overcome these COVID-19 challenges? And I think one of the most important things that clinics can do is to really work on efforts, kind of doubling down on their efforts to remain open, but not without precautions. So symptom screening has been employed, limiting hours, eliminating walk-ins, all these things to kind of place this continued emphasis on remaining open so that screening and treatment can continue to happen. Some clinics, unfortunately, have had to defer routine screening visits, but hopefully that's in order to prioritize those who report symptoms or who report being contacts of STIs or individuals at high risk of infection. And those individuals would include pregnant women, women with symptoms of pelvic inflammatory disease, or those with symptoms concerning for neurosyphilis. And then finally, I just wanted to touch on express visits. So if you look kind of down here, this reference is a Dear Colleague letter from April of 2020 last year. So the CDC has released a series of Dear Colleague letters that guide clinics in how to continue to provide STI care during the pandemic. And one suggestion is these visits where testing and treatment occurs without an exam. And the idea is that the clinics that remain open really can ramp up testing and treatment, or the number of patients they're able to see, and that kind of compensates for these other clinics that are forced to close. One other, or I just want to touch on the other kind of suggestions from the CDC from these Dear Colleague letters, which is syndromic management. So this table over here, you're not really intended to read this fine print, but just to show that this table exists on the CDC website. And in cases where clinics are not open for treatment, for injections, they can kind of utilize these alternative strategies. But really the CDC has encouraged clinics that aren't open for treatment to partner with other local clinics or pharmacies for injections. And then really the oral treatments offered here are a last resort when injections aren't feasible. So moving on to STI prevention and current and potential future methods. So here I'm just touching on some of the current prevention strategies we have in our wheelhouse and some of the future strategies we may have. So condoms, kind of an age-old strategy that have been used both to prevent STIs and pregnancy. Behavioral interventions have been used in the past with some success, either to encourage condom use, reduce number of sexual partners, or otherwise influence sexual activity. Expedited partner therapy, I'll cover in a second. There are also some newer partner services that kind of involve apps or other online resources. Test and treat, which I really look at as a community level prevention strategy. So home testing and rapid diagnostics, which encourage earlier treatment, testing and treatment, and therefore stop ongoing transmission. And then finally, I'm going to talk for a few minutes about vaccines and antibiotic prophylaxis. So here, EPT or expedited partner therapy. This is the practice of treating the sexual partners of your contacts. And people may be familiar with this strategy, but it's providing medications or prescriptions to the client in front of you, and then they in turn provide those to their partners. And the idea is that you reduce reinfection rates and subsequent adverse health outcomes. And so it's important, I think, to keep in mind that EPT should really be viewed as a harm reduction strategy, and so really limited to situations in which a partner would not otherwise receive timely treatment. But I will say it has been studied and it has been shown to be safe and effective for gonorrhea and chlamydia. The EPT was suggested or encouraged kind of last year in the pandemic by the CDC as a strategy to use for treatment of sex partners. But they did release a clarification memo back in May to really discourage its use in the setting of syphilis. So syphilis is just complex, as many of us know. It does require laboratory tests to confirm diagnosis and then follow response to therapy. And so currently the CDC does not recommend the use of EPT for management of sex partners or individuals diagnosed with syphilis. And then home testing can be looked at as another prevention strategy in our wheelhouse currently, and I think it has increased in popularity during pandemic times. So mail-in testing kits are available, generally thought to be reliable. There was a Cochrane review that was published in 2015 that looked at clients who had participated in these programs, and they really liked them. They said they preferred the simplicity, security, and privacy of self-collected specimens, and they reported decreased fear and anxiety that can sometimes be associated with in-person STI screening and treatment visits. And so the CDC mentions in particular, I think as an example, molecular testing labs, which is based out of Vancouver, Washington. It's a CLIA licensed laboratory. The test kits can be ordered by physicians. They're covered by most insurances. But this is just an example. So I would encourage people who are interested in pursuing this further just to review this technical assistance brief that's available online, kind of as a more comprehensive, offering more comprehensive coverage of the self-collection testing kits that are out there. And so here, this map is published by NASDAD. And so these are the states in red here that offer free in-home testing kits. And this includes those testing kits that are offered in partnership with an organization called BHOC, so Building Healthy Online Communities. And so BHOC has partnered with Emory and NASDAD, and then also local and state health departments to offer these free testing kits. So unfortunately, my state over here is gray, but if you live in a red state, you might be in luck in helping your patient get some at-home testing for STIs. And then now, because no talk is replete without a mention of condoms. So again, condoms as our age-old strategy to prevent pregnancy and STIs, but with limited, I think, overall impact in the long term. So this statement from the National Academy of Sciences, Engineering, and Medicine, I don't need to read the whole thing, but they say it's clear, however, that condom promotion alone has not been sufficient in really preventing STIs. And based on the data I showed at the beginning, you know, this epidemic's only getting worse. And so what are some alternative strategies we can think about, study, and maybe employ in the future? So this study is a little bit older. It's coming from Lancet in 2017, but it was a retrospective case control study kind of looking at their mass vaccination campaign with the group B meningococcal vaccine. And so here, this is just showing kind of the proportion of their population that had been vaccinated based on year of birth. And then the actual study involved considering cases, those with a gonorrhea infection, and controls, those with a chlamydia infection. And what they found is that individuals who had received the meninge B vaccine were significantly less likely to be cases, so acquire gonorrhea, than controls. And then when they did some adjusted analyses, what they found was the vaccine efficacy against gonorrhea was at 31%. And so I'll talk more about that in just a second, but also want to mention antibiotic prophylaxis. So this study also published in Lancet ID in 2018, looked at the open label extension of Ipergay, which many of you probably know is a HIV PrEP study, but it was an open label extension that looked at doxycycline for post-exposure prophylaxis, or PEP, as a sub-study. And so it was a randomized open label extension. Patients were randomized either to on-demand PEP with doxy or no PEP. It was 232 participants, and they were followed for about 9 months. And what the analyses revealed was that the occurrence of the first episode of syphilis or chlamydia, and then really all STIs, was lower in this group that received doxy PEP relative to the no PEP group. And then, as you might expect, based on the background kind of resistance, tetracycline resistance rates for gonorrhea, there was no difference here. And I will add that it was generally thought to be, doxy was generally thought to be safe as well, although there was a increased risk of GI adverse events in the doxy PEP group. And so kind of this makes the case for ongoing study. And so the Prevenir sub-study is ongoing in France currently. So this is an open label prospective cohort study. It's an interesting factorial design. So it's looking at both the meningitis vaccine that I talked about a couple of slides ago and doxy PEP. The randomization, so it's taking those who were participants in the PrEP study and then randomizing 2-to-1 to, I apologize here, to doxy PEP or no PEP, and then randomizing 1-to-1 to the meningitis B or no meningitis B vaccine, and looking at STI incidence over time. And Dr. Molina just did provide me with an update that they, the start of enrollment was very significantly delayed, but they have enrolled about 100 out of the 700 people, participants. And they are doing studies of the microbiome and looking at resistance based on cultures and molecular methods as well. And so here is another open label study that's ongoing to look at doxy-PEP to reduce STIs in MSM and transgender women. So this study will enroll, it's taking place in Seattle and San Francisco here in the United States, and it will enroll 780 participants, 390 with HIV, 390 without. It's 2-to-1 randomization, doxy-PEP or no PEP, and we'll look at incidence of gonorrhea, chlamydia, and syphilis. And then similarly, they're doing looking at resistance via culture and molecular methods. They will do stool samples in a select number of participants to look at the microbiome, and then adherence testing with hair levels of tetracycline. And so just to kind of reflect on all these studies that are being done, this figure was taken from a review that was published in Clinical Infectious Diseases back in 2019, but just kind of considering the risks and benefits of STI prophylaxis with the use of doxycycline. So there are implications, I think, for resistance. We do have to consider what changes will take place in the microbiome. Also to be considered, I think not lightly, is side effects and safety. And so, doxycycline is routinely used for malaria prophylaxis and also for acne, generally considered to be safe, but I think not without side effects completely. There are probably going to be studies ongoing to look at the cost and cost effectiveness, and then finally risk compensation, which, as many of us know, has been a issue of great consternation, rightly or not, but within PrEP studies. And so I think my thought on doxy prophylaxis right now is kind of a don't try this at home approach until we have more data. And it sounds like, at least with the Seattle San Francisco study, we can anticipate results in the coming years, likely in 2023. And so now I just want to close talking about STI treatment for a minute, and this update to the CDC treatment guidelines for gonococcus that were released December 18th of 2020. So the punchline here is that there's a recommendation to increase the dose of ceftriaxone, and then also in cases when chlamydia co-infection has not been excluded, to administer doxycycline rather than azithromycin. And so just to talk through some of the rationale for this for just a second. So what's important for antibiotic efficacy when it comes to gonorrhea is the time that the serum-free drug concentration remains higher than the organism's MIC. And so here you have this dose, 5 milligram per kilogram, kind of being the minimum level of drug that meets this criteria. And so put another way, here's 5 milligrams per kilogram, and the time that it remains in this therapeutic duration for serum-free drug concentration above the MIC is about 24 hours. And then here, and by the way, these are all murine models. This is kind of the best we have at this point in time, but this article was referenced in that update as kind of helping to form the basis for these new recommendations. And then here you have, again, 5 milligrams being the minimum dose that was associated with clearance of the organism at 48 hours post-treatment. And so if you think about 5 milligrams per kilogram and what that means for an actual dose of ceftriaxone for the average American, it's going to be more like 500 milligrams rather than 250. So it's just kind of become clear to us, I think, that the 250 milligram dose did not kind of reliably achieve what was needed in terms of pharmacokinetics to clear gonorrhea. And then here is really a figure that shows why azithromycin has come out of favor. So in 2012, ceftriaxone and cefixime was no longer recommended, and ceftriaxone and azithromycin were recommended as the first line treatment. And despite this kind of paradigm of doing dual therapy to reduce resistance, what we've actually seen is an increase in the percentage of isolates that are not considered to be fully susceptible to azithromycin over time. So currently we're looking at around 5% of isolates with reduced susceptibility to azithromycin. So that kind of makes up the recommendation for this transition to use doxycycline instead, to use really ceftriaxone monotherapy without azithromycin. And so then now I just want to specifically cover what the CDC is recommending for uncomplicated gonococcal infections. So when it's a cervical infection, urethral or rectal, the new recommendation is 500 milligrams ceftriaxone as a single intramuscular dose for those weighing less than 150 kilograms. If they weigh more than that, you would administer 1 gram of ceftriaxone. And then in cases where chlamydia has not been excluded, treat with doxy 100 milligrams twice a day for 7 days, unless the patient is pregnant, in which case you would still use azithromycin to treat chlamydia. And then here are the alternative regimens. So it's gentamicin 240 milligrams as a single IM dose with azithromycin 2 grams orally. And then if cefixime must be used, the recommendation now is that the dose be increased from 400 to 800 milligrams as a single oral dose. And then again, with cefixime, use doxy 100 milligrams twice a day for 7 days when chlamydia has not been excluded, unless the client is pregnant, and then still use azithro. And then just to touch on specifically pharyngeal gonococcal infections, because sometimes these can give us the most trouble. So the recommendations here are similar. So 500 as a single IM dose, unless the patient weighs more than 150 kilograms, in which case you use 1 gram, and then use doxy unless the patient's pregnant when chlamydia is not excluded. And then here, just to kind of highlight the things that are specific to pharyngeal infections per the new guidelines, no reliable alternative treatments are available. If there's a reported beta-lactam allergy, conduct a thorough assessment because I think, as most of us know, these penicillin allergies from childhood a lot of times don't pan out when allergy testing takes place. And then if anaphylaxis or severe reaction, consult infectious diseases. And then finally, in cases of pharyngeal infection, a test of cure is recommended at 7 to 14 days. And so that, I think, closes out my slides. And I don't know where exactly we are for time, but we can move into question and answer if that works.
Yes, thank you, Meredith. There's several questions, couple related to the doxycycline recommendation. Obviously, the trade-off is that you're not witnessing people taking the doxycycline. So if you have severe concerns about adherence, is azithromycin still acceptable?
Yeah, absolutely. So in cases where you are questioning the reliability of the patient to take 7 days of doxycycline, then the CDC is recommending that you use 1 gram of azithromycin, and that can be given as directly observed therapy.
And then how long should people be sexually abstinent after being treated for GC or chlamydia as far as transmission?
Yeah. The recommendation is still a week.
Still a week, okay. And a couple of questions. One from Africa Alvarez was about the quadrivalent meningococcus versus the the meningococcal B monovalent that was the data it was based on. Do we know anything?
Well, all the data is to support the group B. And so Bexsero, and I didn't think I had time, but I realized I sort of flew through my slides. So the data is to support group B meningococcal vaccine, and that's, based on that data from New Zealand and other studies. And so what is going on right now is a large randomized clinical trial that I believe, and Dr. Sag maybe can comment, but I think the PI is Dr. Marazzo at UAB, but LSU is actually a site for that study too. So looking at administration of the group B Bexsero vaccine to prevent gonorrhea infection in those not previously vaccinated who are at a reasonable risk of gonorrhea acquisition.
And for the expedited partner therapy, if the partner is a woman of childbearing potential, do you give the partner azithro for the woman or doxy, since you're not going to be doing pregnancy testing?
Yeah, so it's the recommendation is so first of all, you might consider that that patient should be seen in clinic if pregnancy hasn't been ruled out and there are concerns of infection. But yeah, you could do azithromycin if they're childbearing potential. I think there's kind of this gray area in interpretation there. At least the way our clinic is going to implement it is if the woman is of childbearing potential and pregnancy has not been excluded, then we'll still be using azithromycin.
Okay. And regarding the test of cure that you just went over, Stefan Roniak had a question about, if the nucleoside, if the NAD is still positive, do we know that that's not cured? If you're testing 7 days after treatment, you might just be finding dead DNA, right?
So you've got still persistent organism, but maybe dead. So the ideal testing time is probably closer to 10 to 14 days. I think if your test is still positive, you have a serious conversation with the patient about whether they abstain, could have been reinfected, have the patient's partners been treated. But if you're pretty certain that there's been good adherence to your provided recommendations, I think it's reasonable to retest again. If you test at 10 days, test again at 14 to 21 days. But certainly, because pharyngeal infections are notoriously harder to clear and harder to treat, you want to have a high index of suspicion that there may be some treatment failure going on.
And there are several questions about doxycycline. So could you just summarize why this shift away from azithromycin?
Sure. So a couple of reasons, and what I also can do, and I don't know if this could be sent to participants, but if you look on the CDC website, there's actually a link to a webinar that happened in December. It's about a 2-hour webinar with Gail Bolin, Kim Werkowski, and Laura Bachman. But it goes over all the changes that we are going to anticipate with the 2021 CDC treatment guidelines. So those haven't been released yet, so I didn't kind of carefully review those for this talk, but I think it is interesting to kind of get a heads up in what to anticipate, and they very carefully go over the reasoning for the switch to doxycycline. So, but just to hit the highlights, it's sort of twofold with the reasoning. So one, gonorrhea, we're seeing increased rates of azithro reduced susceptibility. So we no longer want to use azithromycin in the setting of gonorrhea. We're going to increase the dose of ceftriaxone, provide monotherapy, and think that that's sufficient with a test of cure in certain situations. In the case of chlamydia, what will be recommended, unless the patient is pregnant or there are concerns about kind of their reliability in treatment adherence, is to no longer use a gram of azithromycin, but instead to use doxycycline for 2 weeks. And so in this webinar, they go into this in great detail. And again, I would encourage participants to watch or to listen to the webinar. But the concern really is the recent data related to rectal chlamydia. There's Julia Dombrowski at UW has published this RCT recently, and I want to say that it was the clearance of rectal chlamydia with azithromycin was about 74% versus 100% with doxycycline. So there's just a big concern lately that azithromycin is not sufficient for rectal chlamydia. And, whether patients are truly having rectal sex or not, or whether they're telling us they are or not, we know that they can test positive despite kind of what they're doing or what they're saying, if only because of auto-inoculation. And so the idea is that really a longer course of doxycycline is needed to treat rectal chlamydia in the case of any chlamydia, diagnosed chlamydia infection. So that was the long-winded answer.
Okay, and there's a lot of questions, and I think we're going to have to refer people to the STD treatment guidelines and to that webinar, but one quick one that I think you can answer very fast. Is there any need for abstinence after treatment for syphilis?
For abstinence for syphilis,
Yeah.
we still recommend 7 to 21 days for our patients. So yes, I do think that it's appropriate.
Okay, thanks. I'll turn it over to Dr. Sag to introduce our next speaker. Thank you very much, Dr. Clement.
Thank you.
Thanks so much. And the only thing I kept thinking about is we're talking about the dosage increasing for ceftriaxone, is that at some point we're going to run out of real estate, especially if people are getting cabotegravir. So we'll have to deal with that at some point.